Your COPD patient was intubated yesterday for a COPD exacerbation. Today, his gas is 7.51, his CO2 is 47, his bicarb is 38, and his PO2 is 79. You do a spontaneous awakening trial. He's awake, he's following commands, being appropriate. So you call the respiratory therapist to do a spontaneous breathing trial. The therapist comes to you afterwards and says, he failed, he went apneic. Why would a patient with that gas suddenly stop breathing? This is ventilator over assistance in a chronic CO2 retainer. Before intubation, his CO2 was high for years. His kidneys compensated, that's why his bicarb was 38. But now the vent has washed out his CO2 too aggressively. His pH is 7.51, that's why he's alkalotic. When the pH rises, the brainstem shuts down the respiratory drive. But in COPD patients, they rely on that CO2 to stimulate breathing. If you drop their CO2 below their apneic threshold, the brain says we're good and stops breathing. That's central apnea. So let's say he's on pressure support of 12, PEEP5, and an FiO2 of 30%. If the pressure support is too high, he gets big, easy breaths. He hyperventilates, the CO2 drops, and the drive disappears. The problem is not sedation, it's not muscle weakness, it's a ventilator strategy problem. So what do you want to do in this patient? You want to fix the vent. If he's on a pressure support of 12, you can drop it to 10. See how he does on 10. If he does well on 10, then drop it to 8. See how he does. You also want to keep an eye on his tidal volumes. If they're around 8 to 10 milliliters per kilogram, that's way too high for a COPD patient. And he's being overventilated, which will contribute to his respiratory alkalosis. The goal is to allow the CO2 to rise towards baseline. You're not targeting a pretty CO2 here. You're targeting a reasonable pH. So you want to let his CO2 drift back up to the 50s to 60s if that's his baseline. And you'll know what his baseline is once his pH returns to normal. So when you allow the CO2 to rise, the pH will come back towards normal and the drive to breathe will return. So this is what I want you to remember. If you have a COPD patient and they're apneic on the vent, check the pH. If it's above 7.45 in a chronic CO2 retainer, that means the ventilator is overcompensating, blowing off too much of the patient's CO2. Correct the alkalosis and the drive to breathe comes back. Save this for your next apneic COPD patient.